Clip is a good idea. I asked Dr. Estep and he said clip. I said LVAD. Usually we do the other. So I'm going to do this on behalf of my colleague, Dr. Barker, who's an interventionalist. And while I train as an interventionalist, as a disclaimer, I have to tell you I don't perform this particular procedure. But I'm also, as another disclaimer, I'm a consultant for a company that does the coronary sinus device, and I'll show you some data on that. So I'm going to review some of the data and show you a nice case that Colin did. So I'm going to talk about classification, just look at the prevalence, see some outcomes, go over maybe the description of the Cohort trial, which I think is a very important study that will help us define the real role of this technology. So let me walk through you this case that our Colin, who was supposed to be here, our colleague did this past year. It's an 85-year-old man with CAD, chronic atrial fibrillation, previous CAF, low EF, ICD, chronic renal insufficiency, has significant MR and AS, worsening dyspnea, minimal exertion, hospitalized twice, pretty much like Walid's case that presented. And it's well treated with the optimal medical therapy. So there is really not much you can do. So he went ahead and did a MitraClip, and you can see this in 3D echo. You see the device coming in and the clip facing down the valve. And I don't think I can show you this next one, but you can see the clip here, which it mimics the alveoli stitch. And this patient, after the procedure, has very insignificant or trivial amount of MR. So he was able to correct the mitral insufficiency. And of course, the patient needed also treatment for the aortic valve because the patient not only had bad MR, but also bad AS. And this is actually an interesting thought because in many cases, once you fix the AS, the severity of the MR decreases. In this particular case, they chose to do the mitral first. Many other, or an alternative strategy would have been fix the aortic valve and then you go to the mitral. And here is the positioning of the aortic valve. And so this represents what's possible today with interventional cardiology, where you can do mitral, you can treat the mitral valve, you can treat the aortic valve in what was inconceivable 10, 15 years ago. These things were unimaginable, that you could interventionally fix valvular heart disease in a patient that's severely ill like that. So I think that's a nice illustration of what we will see much more in the future. So MR is age-dependent, affects This is aortic stenosis. The prevalence is age-dependent, of course. Calcific aortic stenosis is a big problem. In mitral valve disease, we're going to go over in a moment, the excess mortality occurs for medical management and delays in intervention for both mitral and aortic valve disease. Surgical risk and etiology determine the timing of intervention and of course, the importance of the intervention. When we talk about MR, it's very important to divide and understand MR as primary when the valve is defective or secondary when it's the response to a ventricle that's failing, as in the previous case that Willie presented. This is a case of a nice myxomatous valve. The valve is degenerated. It prolapses. Typically, prolapse with the posterior leaflet. Both leaflets can prolapse. And this is the condition where the ventricle is ill, defective, and whether it's the chordae, therein, the geometry of the annulus or the geometry of the ventricle leads to malapposition of the valves and a significant degree of MR. And there's a quite significant assessment and evaluation of both conditions. So let's look at the prognosis and at the severity of the disease, the severity of the dysfunction, and the symptomatology. This, I think, that you alluded to just a little while ago, and this is data from Enrique Serrano from many years ago, looking at EF and surgical outcome. This is survival over time, and patients that had an EF of more than 60% had a survival advantage was much superior than those that had an EF of less than 50%. And I think the important observation here that one has to remember is that when you have AMR, the degree of loading is so powerful that we almost always overrepresent the assessment, the EF assessment by echocardiography. So an EF of less than 50%, even in the range of 50 to 60%, is an abnormal EF. And it represents and it has a significant impact in prognosis, as shown in this slide. So EFs less than 60% represents a significant abnormal EF in severe mitral regurgitation. Now, untreated severe MR is associated with increased morbidity and mortality. We clearly know that. What is the impact of therapy? And I would say, and how do you define, at what moment do you define the severity of MR? Do you define MR at the moment the patient comes with acute decompensated heart failure? Do you wait to have optimization of treatment? And in general, that's the rule. You have to wait until the patient is optimized so that you can actually assess the severity of MR. This is a slide that shows the population at risk with significant MR and the number of patients that undergo mitral valve surgery. So only about 2% of the patients that suffer from MR that are potentially candidates are treated surgically. The incidence of patients that have MR grade 3 or more is about 250,000, eligible for treatment at a significant greater number, and the total number of patients with MR may be more than 4 million. The prevalence in the population is quite significant, as you can see. And I think that the population that today is not treated represents over 1.5 million people. So what is the spectrum of therapy? Of course, you can do therapy, and I suggest to you that in a large number of patients that would come to the hospital, decompensated, and you assess at that time severe MR, following optimization of treatment, the degree of MR will significantly lessen. So medical therapy is an important part of the armamentarium. We have MitraClip, and I'm going to show you also the coronary sinus device, and then mitral valve surgery. And in the future, or now, you'll see transmitral valve replacement as well for some selected patients. So less invasive strategy for medical therapy, and the power to reduce the degree of MR is proportionally in this direction, perhaps with mitral valve surgery being the most effective. So let's go over the general principles of therapy. For primary valve disease, there is really no medical option for valve treatment other than optimization of hemodynamics with guideline-directed medical therapy. Surgery is for symptoms or LV dysfunction, and the asymptomatic patient, if repairable, at low risk, should be repaired. In fact, the primary treatment option should be surgery for patients that are asymptomatic or those that have some LV dysfunction. And clearly, one has to prevent further deterioration of LV function because of the impact in mortality, as I showed you earlier. But it's important to recognize that we don't really have medical therapy to treat this condition. We have medical therapy to define with clarity the severity of MR that may be worsened by a decompensated hemodynamic state. For patients that have secondary valve disease, I think medical therapy is first. That means we have to optimize the condition. You have to give proper guideline medical therapy. Consider CRT as properly stated in the case as Wally presented to us. If there are candidates for CRT, CRT is a very useful way to decrease the degree of MR. In fact, most of the patients that respond well symptomatically are those that have MR. And the question of surgery, I think that it is a question of importance. And I reviewed with you yesterday the trial from the collaborative surgical trial group, randomizing repair versus replacement in patients with ischemic MR. And I think it's an important consideration. It appears that as shown in this slide, there is very little or insignificant, mortality benefit when you do it with surgery. And the reason is that there is significant comorbidities associated with the secondary condition. And whether you replace or repair, no significant difference in outcomes. An increased number of patients will require repeat reoperations if you repair compared to replacement. And it may be that replacement will be the better choice, but there doesn't appear to be a significant survival advantage whether you replace or repair or not. Symptomatically, clearly there is. The MitraClip system is shown in this slide. It requires a significant experience. I'll show you data in the first case that we presented. It's a transseptal puncture, and the clip reproduces the Alfieri stitch, as you can see here. You can do more than one clip, depending on the condition, depending on the case. As you see in here, the clip today is indicated for percutaneous reduction of significant symptomatic MR due to primary abnormality of the mitral apparatus. That is, for those patients that have myxomatous or degenerative MR, in patients that have prohibitive risk for mitral valve surgery. And I would qualify this by a heart team. It is not the same, the definition of a high-risk patient in a community hospital versus in a tertiary center where you can evaluate patients in a comprehensive manner. And I think this has been a recurrent theme through some of our presentations in this meeting, where the importance of full evaluation by comprehensive teams. I can tell you that we are faced sometimes as a referral center in the US with patients that are deemed non-operable or end stage or significant or high risk by other centers, that when you evaluate in a comprehensive manner, those definitions vary substantially. So this is a very important definition and is the FDA approved indication in the US. ACC/AHA guidelines for primary MR said it may be considered for patients at prohibitive risk with primary MR and severe symptoms despite guideline-based medical therapy, and that's a Class 2B indication. So there's an ongoing experience, and the data I'll briefly would discuss here with you. These two trials show feasibility, a pivotal trial that it encompasses about 320 patients. There is an open registry that has over or close to 1,000 patients. And worldwide, there have been over 15,000 implants approved in the European community, while in South America, and approved for that restricted indication in the US, which leads to an off-label application in a number of patients. Now, I think what defines a very prohibitive surgical risk cohort, I think in this particular study, an STS score of 13.2, significant history of prior stroke, diabetes, COPD, renal disease, and very old patients. I think that's an important observation. So I think one can say today that MitraClip therapy appears to be safe in reducing functional MR in patients at prohibitive risk for mitral surgery. In this group of patients, it provides improvements in reduction of volumes, improvements in New York Functional Class, quality of life, and reduction of hospitalization for heart failure. But I think the proof and for widespread acceptance of this is going to be as it results from the Co-op trial, at least in the US. And the trial will evaluate the safety and effectiveness of the MitraClip system for treatment of functional MR graded more than 3+ in symptomatic heart failure patients who are treated with a standard of care, who are determined at the site by a local team not appropriate for mitral valve surgery. And I cannot emphasize the importance of that, because as we embark in therapies for high-risk patients with VAD, transplantation, advanced valvular heart disease, you have to consider the importance of a comprehensive collaborative team effort. It cannot be done by a wise physician or a wise surgeon. That's just not the norm today. So the Co-op trial is a 402-patient trial enrolling at 75 sites in the US. And the criteria is listed in here: significant FMR more than 3, high risk for mitral valve surgery, STS more than 8, the specific valve anatomy criteria that would make it suitable for mitral clipping, randomization 1 to mitral clip, 1 to the standard of care, and they will be follow-up over time. This, in case you want to look at it, I just reviewed earlier today, this is a clinical trial GOP number identifier, and the trial is continuing to enroll. And the objective is simple, is to evaluate the safety and effectiveness of the clip for the treatment of functional MR in symptomatic patients who are at high surgical risk. So primary endpoints are shown in here. The primary effectiveness endpoint is recurrent heart failure hospitalization, and a primary safety endpoint is a composite all-cause death, stroke, worsening kidney function, or LVAD, or cardiac transplantation. So I'm going to move now to another device, which is easier to implant. that also is approved now by the European community. I spoke to Steve Goldberg, who's one of the primary implanters of this device, and I believe that someone here in Saudi was trained. I think it's in Riyadh. He told me last week that he had been here proctoring for the use of the CARILLOM mitral contour system, which is a very simple technique. I'll describe it briefly with you. And it provides another potential that needs to be examined further. And as you can see here, this is a device that's placed along the coronary sinus. This is a delivery system. I think I have another picture here. This will be the introducer that will be located into the coronary sinus. It's an IJ puncture, and the system will allow you to deliver the distal anchoring position of the device distal into the coronary sinus. There is another anchoring position proximally. I will not be able to play this picture, but if you go into the Cardiac Dimensions webpage, you can look at it and you can play it. It's very nice. It shows you the simplicity of the procedure. It has, like everything, caveats. You have to watch coronary flow. Make sure that you don't occlude the circumflex as it goes along the coronary sinus. This is the way it would look in an X-ray, the way the device is implanted. The device can be retrieved, and that's an important consideration. In the study that I will show you, it's called the Titan study, the control patients were patients in whom the device was retrieved. So let me go over briefly in the last few minutes on this particular device. This study was evaluating the impact of the mitral annuloplasty in heart failure patients with at least moderate to severe FMR with the mitral contour system CARILLOM. Patients in whom the device was placed and then captured because of lack of inducing ischemia or malapposition or not properly reducing the degree of MR, serve as control. So these were patients that were all attempted to be implanted. The active treated group remained as the intervention group, and those in whom the procedure failed, if you will, serve as the control. And a lot of quantitative measures by echocardiography and functional status were performed. So I'll just highlight a few, just for you to see. This is the regurgitant volume, and this is the control group, and this is a reduction in volume observed in those treated patients. This is LV end diastolic diameter over time. This is the progressive increase in the control group and a significant decline in the active treated group. And I think that at this moment, this cardiodynamic procedure is in the process of setting up a large multi-center study in North America and in Europe to try to answer the definitive question, just like in the co-op trial. And I think that we will see launching of this study hopefully in the next few months that will define, just like the MitraClip, the proper positioning of this technology for patients with valvular heart disease. So let me just summarize this by simply saying that the interventional techniques that we will be facing in the future for patients with FMR will be mitral clipping, the mitral annulus contour, and for some selected patients perhaps in the future, mitral valve transfemoral transcutaneous mitral valve replacement for some individuals. I'd like to close with this, the presentation, and maybe looking forward for questions.